Today's topic is transport of oxygen and carbon dioxide in blood. The respiratory system and circulatory system together it work for transport of oxygen, that is from the lung to tissue, and the carbon dioxide is taken up by the venous blood and it goes back to heart, right heart, and from there it is exhaled out of the lung. Now there are various forms in which this oxygen as carbon dioxide is transported in the blood, and we are going to discuss all those and what are the factors it affects this oxygen and carbon dioxide transport in our body. First, we are going to discuss about the oxygen transport and the form in which the oxygen is carried in the blood. As we know, 1 gram of hemoglobin can bind with 1.3 ml of oxygen. And what is a normal value of hemoglobin? It is approximately 15 gram per deciliter. That means 100 ml of blood can contain 15 gram of hemoglobin. And if we multiply, it comes that normal hemoglobin with the 15 gram per deciliter, there is a 20.1 ml of oxygen. In that, due to physiological shunt, there is 97% of hemoglobin is available for carrying the oxygen, not the 100%. So what is happening? From 20.1, it becomes 19.8 ml of oxygen, which is carried by this 100 ml of arterial blood. Out of that, there are two forms in which this oxygen is carried. One is maximum amount, which is will be carrying by this hemoglobin, that is 19.5 ml of oxygen is carried by oxyhemoglobin, that is a hemoglobin and oxygen together it forms oxyhemoglobin, and very little amount, that is a 0.3 ml as dissolved form in the plasma. Though it is very less, this dissolved form, it is very important because this is the form in which first it goes to the tissue. If it is oxyhemoglobin, also from hemoglobin, the oxygen first dissociate, then comes into the dissolved form. In the dissolved form, it diffused to the tissue. So it is very important. So other than this dissolved form, because of this, if the partial pressure of the oxygen is increased, the dissolved form of this is also increased. And the hyperbaric oxygen is used because of the dissolved form will increase, and it will actually it helps in treating the carbon monoxide poisoning or anaerobic infection or gas gangrene like clinical condition. As the maximum portion of the oxygen is carried through hemoglobin, so we have to know the structure of hemoglobin better. Now here we can see that hemoglobin is consisted actually present inside RBC, and it is consisted about two things. One is a heme and the globin part. The globin part of the hemoglobin, adult hemoglobin, consists of the 4 polypeptide chains, 2 alpha and 2 beta. And each polypeptide chain contain a heme molecule. In the heme molecule, there is iron is present in the ferrous state. This is very important. It is present in the ferrous state, and the iron has a capacity to bind with oxygen atom. So if there is a 4 iron atom in this, so this iron can, in the ferrous state, it can bind with the 4 molecule of oxygen. Now a little bit about the other type of hemoglobin also. What are those? The normal hemoglobin, that is a hemoglobin A, it is maximum in the normal people, that is 95%. And hemoglobin A2, it is less than 3.5%. Hemoglobin F, which is very important. And we have to know the hemoglobin F, how oxygen is carried in this. And the chemical structure of this is hemoglobin A is 2 the polypeptide chain, that is a alpha 2 and beta 2, whereas hemoglobin A2 is alpha 2, delta 2, and hemoglobin F is alpha 2 and gamma 2. Why we are concerned about this polypeptide chains? Because of changing of this beta, gamma and delta, the affinity of hemoglobin towards oxygen also changes. So it is very important to know the which type of polypeptide chain are present in which type of hemoglobin. Now, hemoglobin, how it binds with oxygen and what is the change it happens when it binds with oxygen. So, formation of oxyhemoglobin step by step we are going to discuss. First, the hemoglobin molecule made up of 4 subunits. We know the 4 subunit. These are the 4 subunits, and each contains a heme molecule which has a ferrous iron and which is going to bind with the oxygen. Now, each subunit consists of the molecular group known as a heme. Then each heme group contains one atom of ferrous to which the oxygen binds. Okay. Now the single hemoglobin molecule, because of there is a 4 subunit of heme molecule, so in a single hemoglobin molecule can bind with the 4 molecules of oxygen. Right. Now the hemoglobin binds to the oxygen only when the iron is ferrous state. That is very important. Now, when oxygen is not bound with the hemoglobin, this is called the deoxyhemoglobin. The 4 subunits of hemoglobin are tightly bound. Come to this diagram. These are tightly bound with each other. All polypeptide molecules along with the heme, they are tightly bound. No end is open. Okay. And this configuration is called, when it is tightly bound with each other, this is called the tense or the T state of the hemoglobin. So it has very less affinity towards oxygen and mostly it is deoxyhemoglobin. Now, because we know there is 4 molecules of oxygen can bind with a 1 hemoglobin. So what happened? The 4 molecule doesn't bind together one by one, step by step. One molecule will bind with hemoglobin, so it will change little conformational change and then the binding capacity will increase more. So it step by step it increases the binding capacity or the affinity towards the oxygen, and it forms when the first oxygen molecule binds with the hemoglobin, the 4 subunit, this 4 subunit enters into the relaxed state. Means before it was like this, then later part after binding with the 1 by 1 oxygen it becomes relaxed, and the conformational change, due to conformational change, the angle between this polypeptide chain is gone relaxed by 15 degree, and this state is called R state. And this clinically important is the R configuration, the affinity of the hemoglobin for the oxygen, it increases by 200 to 500 times. So T state, when it is deoxyhemoglobin, it is tense state, and the relaxed state when the oxygen is bound with that and it increases the affinity by 200 to 500 times. Now the conversion from the T state to R state. When oxygen is binding with 1 hemoglobin, the bond or salt bridges are successively broken, and we are going to discuss with the diagram. So the is the T form or the tense state. You see the salt bridges are there, alpha 1, alpha 2, beta 1, beta 2, and there are the salt bridges between these. So 1 molecule of oxygen is binding with that one salt bridge is broken and the oxygen is binding with that, and it becomes this hemoglobin O2. Then another molecule, hemoglobin, another O4. That like this, whenever the 4 molecule of oxygen is bound with this all the salt bridges, these are the salt bridges, all the salt bridges are broken. It is in the R form, and the affinity of this has become 200 or 500 times more. Now we are going to discuss about the percent saturation of hemoglobin. What is that? If all 4 sides of the hemoglobin are occupied with oxygen, that is 1.3 ml, that is called the hemoglobin of hemoglobin is 100% saturated. That means one hemoglobin, if the 4 sites are occupied, then that hemoglobin molecule is 100% saturation. Now percentage saturation means is the average saturation of the entire hemoglobin molecule. Means how much hemoglobin that person is having and how much hemoglobin, how much percentage of the hemoglobin is saturated with the oxygen, that is called the percentage saturation. How can we calculate? Calculated by the oxygen content of the blood per 100 ml. Okay, 19.8. Okay, total oxygen content of the blood is that, and oxygen carrying capacity of the blood divide by that into 100 is the percentage saturation of hemoglobin. Now, after percentage saturation, we are going to know about the oxygen content of the blood. That is quite different from the percentage saturation of the hemoglobin. And what is the clinical importance in that? First, we have to know what is oxygen content. Oxygen content means the volume of the oxygen contained in the one volume of blood. Okay, it includes both the bound with the hemoglobin and the dissolved in the plasma, both. So suppose for the anemic person, what will happen in case of anemia? The hemoglobin content is less. So obviously the bound oxygen with the hemoglobin will be less. Though the oxygen content is more important than the partial pressure of the oxygen and the oxygen saturation for the tissue. And the patient with this anemia has a 7 gram percent of hemoglobin or less. So bound oxygen is less. So this causes the oxygen content of the oxygen content is grossly reduced in case of this anemic patient because of the hemoglobin is less, that is 7 gram percent, and the oxygen content is bound hemoglobin and the dissolved state also. So the oxygen content in this anemic patient is grossly reduced and the tissue suffer from hypoxia. What is hypoxia? The decreased partial pressure of the oxygen in the tissue level is called hypoxia. And mainly the tissue is getting oxygen by the oxygen bound with the hemoglobin. Because of the hemoglobin is less, the tissue suffer from hypoxia, though there is a normal arterial PO2 and hemoglobin saturation. As we know, one of the most important function of hemoglobin is to carry the oxygen. The first oxygen has to be taken up from the alveoli and it has to bound with the hemoglobin to form oxyhemoglobin, and in this form it has to be carried to the tissue where it has to dissociate to supply the tissue for the metabolism. Now, if we plot the percentage saturation and the oxygen dissociation in the association and dissociation in the lung level and the tissue level, the graph what we will get is called oxygen hemoglobin dissociation curve or oxyhemoglobin dissociation curve, which is sigmoid shaped. Now, how it is? It looks like this. We'll start from here. X-axis is a partial pressure of oxygen. It is in the millimeter of Hg, and y-axis is percentage saturation of hemoglobin that we have discussed already. Now what is happening? We can see this is not a linear graph, rather it is a sigmoid shaped. Okay. What is happening? It would have a linear graph if increase of partial pressure of oxygen increases directly to the percentage saturation of the hemoglobin exponentially, but it is not happening. It is not happening linear. It is not increasing in the linear fashion. Whenever the partial pressure of the oxygen is increasing, the percentage saturation is increasing. It is not happening. So why this oxygen dissociation curve is in sigmoid shape? It has to be clear. We have to start from this level. You see here we know the alveoli, the partial pressure of the oxygen is 100 ml of 100 millimeter of Hg. At that level you see the percentage saturation of the hemoglobin is obviously 100. But it doesn't, because of the percentage saturation decreases to 97 because of the physiological shunt. Now you see here this from 100 millimeter of Hg to 55 millimeter of Hg. We can see here this is the level. This is the 50 millimeter of Hg, or you can say the 60 millimeter or 55 millimeter of Hg. The percentage saturation is 90. That means from 100 to here 55 millimeter of Hg, the hemoglobin remains saturated for 90%. So this part of the graph is called flattened part, and this flattened part is actually a safety factor. I'm coming later. Now after that, what is happening after this level? decrease in partial pressure is acutely decreasing the percentage saturation of hemoglobin. Okay, as we know, in the tissue level the partial pressure of oxygen is 40 millimeter of Hg. Now you see this at the level of 40 millimeter of Hg, the percentage saturation of hemoglobin comes down to around 85. Why? Because of at this level, from this 90, already the oxygen has been dissociated, started dissociating from hemoglobin to the tissue because of this partial pressure gradient. From 100 it is 40, so it is a 60 millimeter of difference, 60 millimeter of Hg difference. The oxygen started dissociating and more decreasing partial pressure of the oxygen it is coming. So this is called the steepest part of the oxygen dissociation curve, where this is the unloading happening. This is the unloading happening. So after this, whenever the hemoglobin is reached to the tissue, the unloading of oxygen, which is very much important for the metabolism. So this steepest part of this graph is called the unloading part of the dissociation curve. We'll discuss a little more regarding this oxygen dissociation curve. Come to this diagram first. You see here, again, the sigmoid shaped curve. This is the partial pressure of oxygen and this is the percentage saturation. We have discussed in the earlier graph. 100% 100% PO2, 100 millimeter of Hg PO2, 98% of the hemoglobin saturation, whereas 90% hemoglobin is saturated at the level of the 60 millimeter of Hg. After that, you see the change is very rapid. The 50 to 10, there is 92 become 14 millimeter of Hg, 14 per gram percent of percentage saturation of the hemoglobin. So this is very important to know where and which condition the unloading happens. So the curve shows that the PO2 value is 100 millimeter of Hg or above, that the 100% of saturated. And there's a PO2 falls to 60, the percentage saturation is 90. And the steep portion of the curve starts after 60 millimeter of Hg, and the steep part is mainly the unloading or dissociation are concerned with the delivery of oxygen to the tissue, and the large amount of the oxygen can be delivered to the blood, relatively minor fall of oxygen tension. That is very important. The partial pressure of the oxygen lower than 50 millimeter of Hg and has a still larger volume of the oxygen would be unloaded. So it is a reservoir actually. After 40 also, so much of oxygen can be delivered, because during reserve condition means during exercise it has to deliver more amount of the oxygen. Physiological advantage of being the S-shaped dissociation curve. This is the S-shaped dissociation curve. We can see the steep part is called unloading zone and the loading zone. So loading is happening, loading of oxygen happens at the lung level and the unloading happens at the level of tissue. The loading partial pressure of is 100 millimeter of Hg, where the tissue level is 40 millimeter of Hg. What are the importance? It allows a greater uptake of the oxygen at the lung despite of the great variation of the alveolar PO2. And tissue are supplied with oxygen according to their needs. How much is required, the oxygen will be delivered that much only. And the hemoglobin acts as a buffer to maintain the tissue PO2 at the level of 40 millimeter of Hg. And the flat part of the curve is called the loading zone, that happens in the lung level, and the steep part is called the unloading zone, which is happening at the tissue level. Now the factors which affects the oxygen association in the lung and dissociation in the tissue. If we plot that, the curve will shift either right side or the left side. Now what are the factors which affects the right and left shift of oxygen dissociation curve? First we start with the right shift. This is the normal one. This is the middle one is the normal curve which is supposed to be. But when it is shifted to the right side, that means it is dissociating more amount of the oxygen to the tissue. Increase of the P50 we'll discuss later. Increase in the P50 means decrease affinity, increase in temperature, increase in carbon dioxide, increase in 2,3-DPG, and decrease in pH. We will discuss individually later. The opposite happens. It shifts towards left when there is a decrease in temperature, decrease in carbon dioxide, and decrease in 2,3-DPG and increase in pH. So you think the temperature when it is increasing means the person is exercising. If the person is exercising, that means the tissue needs more amount of the oxygen. So it has not to be bound in oxyhemoglobin form. It has to be dissociated faster. So this dissociation is more, so it is shifting towards the right. Because of the metabolic activity, the oxygen carbon dioxide production is also more. Because of the carbon dioxide production, this pH is also decreased. And 2,3-DPG we will discuss separately. So these are the factors when there is need of the oxygen is more towards tissue, the dissociation curve shift towards right, and it happens opposite when this factor increases. Now, a very interesting part of the dissociation we are going to discuss, and you have to think why we are discussing so much for this dissociation curve, because the oxygen has to be dissociates from the hemoglobin to the tissue, and it has to be very fast depending on the metabolic activity what is happening in the tissue. So what are the factors which affects, and another factor which affects and brings the oxygen easily available in the tissue is a Bohr effect. What is Bohr effect? We can see here, this is a oxygen dissociation curve. Blue one is a normal one with the normal pH is 7.4. What happened when there is acidosis? Means the carbon dioxide production is more, or there is a carbon dioxide, ultimately carbonic acid, so pH is more less, and there is acidosis, okay, called physiological respiratory acidosis, or it happens to the hypercapnia also. Hypercapnia. So capnia means increase in carbon dioxide concentration. And what is happening here? It is towards the left side. The green one is a left shift of this. pH has been increased. It's called alkylosis and hypocapnia. So what is this? An increase in what is Bohr effect? An increase in PCO2, and decrease in pH shift the curve to the right is called Bohr effect. So this is pH is decreased, that is from 7.4 to 7, causes acidosis, and because of this pH is shifts towards the dissociation curve shift towards the right side, and this is called Bohr effect. In the tissue, there is an increase in cellular metabolism, and increase in cellular metabolism increases the partial pressure of the carbon dioxide from 46 millimeter of Hg, which decreases the pH from below 7.4, which is the normal one. And then the high partial pressure of the carbon dioxide level loses its affinity towards oxygen. Because of the carbon dioxide concentration, partial pressure of the carbon dioxide concentration in tissue is 46 millimeter of Hg, hemoglobin loses its affinity towards oxygen, which it was carrying from the heart through the systemic circulation to the capillary bed. Now, whenever it's losing its association, it will release to the tissue, and the curve will shift towards right side. This is called the Bohr effect. Due to this physiological respiratory acidosis, the right shift of this oxygen dissociation curve is called Bohr effect. Now, as we have discussed, we have missed one thing. What is the effect of 2,3-DPG? What is the full form of 2,3-DPG? It is 2,3-diphosphoglycerate. As we know, the RBC is a divider of mitochondria. So the metabolism is obviously anaerobic. And because of the anaerobic glycolysis, this 2,3-DPG is formed inside the RBC. And this 2,3-DPG competes with this oxygen for binding with the hemoglobin. So between these two, 2,3-DPG and oxygen, this has 2,3-DPG has more affinity towards hemoglobin. So when this 2,3-DPG is highly charged anion that binds with the beta chain of the deoxygenated adult hemoglobin. In the presence of oxygen, it binds with the beta hemoglobin beta chain, but in the 2,3-DPG it's bind with the beta chain of the deoxygenated hemoglobin, and which increases the concentration of the 2,3-DPG, decreases the affinity of the hemoglobin for the oxygen. Oxygen binds with the hemoglobin heme part, whereas the 2,3-DPG binds with the beta chain. If already the 2,3-DPG binds with the beta chain, this oxygen cannot bind with the hemoglobin more. So what is happening? This is shift the normal oxygen dissociation curves towards the right, because this is oxygen is available more to the tissue, because it is not bound with the hemoglobin. Instead of that, 2,3-DPG is bound with that. Now come to this diagram. This is oxygen dissociation curve. This is the normal one, you see. This is the 5-2,3-DPG, and when happened 2,3-DPG is increased, it has shifted towards the right side. Decrease, this 2,3-DPG decrease towards the left, and if 2,3-DPG is not alone or not at all present, this is the oxygen dissociation curve. This is almost flat part is more, means association is too much and there is less unloading. So this tissue level increase in 2,3-DPG helps in unloading of oxygen. If there is 2,3-DPG, no 2,3-DPG, then unloading is less, whereas the more 2,3-DPG, unloading is more and it shifts towards right. So hypoxia stimulates the 2,3-DPG because it is an anaerobic metabolism starts. So condition like anemia, exercise and high altitude, very important, high altitude, 2,3-DPG concentration increases and the unloading of the oxygen is more towards tissue and availability of the oxygen is more, doesn't suffer from hypoxia. Tissue doesn't suffer from hypoxia. So in this situation, it shifts towards the right side. Now the other importance of 2,3-DPG present in the blood for oxygen transport in case of fetal hemoglobin. As we know, the fetal hemoglobin is not the alpha 2 beta 2. Instead of that, there is a alpha 2 and gamma 2. And last slide we have discussed this beta chain has a high affinity towards the 2,3-DPG, okay, which allows the oxygen to release, to unload. But instead of this beta, which is present, is a gamma. So 2,3-DPG, because of this 2,3-DPG has a low affinity towards this hemoglobin F, because the beta chain is not present. So what is happening? Higher binding affinity of the oxygen happens in case of fetal hemoglobin. Because of the beta chain is not there, gamma chain is there, and this gamma chain has lesser affinity towards the 2,3-DPG. So there is competition is less, and that instead of 2,3-DPG, oxygen binds with the gamma chain more. So what is the advantage? Advantage of this is that it extract hemoglobin, fetal hemoglobin extract more oxygen from the maternal blood in the placenta, and this fetal hemoglobin dissociation curve shifts towards left side. That means unloading is more and the carrying of oxygen with it is maximum. Now stored blood, what happens in the blood bank blood? 2,3-DPG is less. As we know, the last graph we have seen that the 2,3-DPG is less, means the unloading of oxygen is also less. In case of this 2,3-DPG concentration in the red cell is stored blood is less, so unloading decreases. It doesn't affect so much in case of transfuse in the patient if it is a hypoxic patient. In the hypoxic patient, if you give the stored blood which has a 2,3-DPG concentration is less, in that case the unloading of the oxygen is less, so hypoxia won't be treated in that case. Now the P50. What is P50? P50 is the level of the partial pressure of the oxygen when 50% of hemoglobin is saturated with oxygen. Again, P50 is a partial pressure of oxygen when the 50% of hemoglobin is saturated with oxygen. Come to this graph. This is the oxygen saturation. This is 100%. This is 0. So this is the middle. This is the 50%. 50% of the hemoglobin in which partial pressure it is saturated is called the P50. Okay, in case of normal person in the normal sea level, this is 27 millimeter of Ag. You see the 27, this is the 20, this is 40, this is 27 millimeter of Ag of partial pressure. The 50% of oxygen is saturated usually, normally. Now what is the clinical importance? If this will increase, the loading will be affected. Of it is decreases the P50 value, then also unloading will be affected, not loading, unloading. So what is happening here, the alteration of the P50, if it is high means increases. P50 usually sea level is 27 millimeter of Hg, 50% saturated. If it is increasing, if it increased to the 40 millimeter of Ag, 50% is saturated. That means the graph will be moved towards right side. That means it is dissociation of the oxygen from the hemoglobin is more. In opposite side, when it decreases, that means 27, it is coming 20, that means it is 50% is saturated. That means the graph will shift towards the left side. That means the dissociation is lesser. So this P50 high means dissociation is higher, decrease in affinity of the oxygen, there will be more unloading. And if it is decrease, that means the shift will be on the left side, unloading will be lesser, and the affinity will be greater towards hemoglobin. Now, instead of hemoglobin, the muscle contains a special molecule called myoglobin. And the myoglobin dissociation curve is a little different from hemoglobin, how it looks. And this is also PO2, this is oxygen saturation. You see, this is the hemoglobin dissociation curve, whereas it is not at all a sigmoid shaped curve. Now, myoglobin is a hemoglobin pigment in the muscle. And though it is a similar to the hemoglobin structure, but the oxygen, 1 mole of oxygen per mole, 1 molecule of oxygen per mole of myoglobin. And in exercising muscle, this myoglobin production is more. When the muscle is exercising, the myoglobin production will be more. And because of this binds with the more, and affinity of this myoglobin towards oxygen is more. This is shift of this curve will be towards left side, and it is not at all sigmoid shape, it is a hyperbolic. It helps in the picking up, means loading of the oxygen. What is the importance? What is the physiological importance of more oxygen carrying capacity than the hemoglobin? To the exercising muscle, myoglobin increases in the exercising muscle, so increase in oxygen carrying capacity during exercise. Normal resting condition, the hemoglobin will take care. But if the muscle is exercising, the hemoglobin alone cannot supply the oxygen. In that case, the myoglobin has to come into action. Because of compared to hemoglobin, myoglobin has a more affinity towards oxygen. In exercising muscle, during exercise, the oxygen supply is one mode of the oxygen supply after the hemoglobin is a myoglobin. It helps during when there is a, suppose one person is doing a weightlifting. Because of the weightlifting, what is happening, this type of muscles are working more. There is isometric exercise, so what happened, the muscle are having, because of the muscle contraction, the blood vessels are compressed, blood supply is less, so hemoglobin is not coming in that situation. So what will be the supply, what will be the mode of the supply in that case? The myoglobin will be the main mode of the supply of oxygen in exercising muscle. Now, the carbon dioxide transport in the blood. The carbon dioxide actually produced during the aerobic cellular metabolism at the tissue level, and it has to be transported from the tissue to the lung and through the venous blood, and it has to be exhaled in the air. The form in which the carbon dioxide is mainly transported first is a physically dissolved in the plasma, 7%. So a little amount, 7% is physically dissolved. Maximum amount of the carbon dioxide is transported in the form of bicarbonate, that is 70%, and in the plasma and in the red cell, both in the red cell and the plasma, the bicarbonate is present, and that is a main mode of carbon dioxide transport. and the rest 23% is as a carboamino protein complex in the two way. One is compound with the plasma protein and carboamino hemoglobin. What if the protein is present in the hemoglobin with that carboamino hemoglobin? Dissolved form in the plasma, carbon dioxide. The amount of the carbon dioxide dissolved in the plasma is proportional to the partial pressure of the carbon dioxide, as like the oxygen. The partial pressure of the oxygen, carbon dioxide, if it is increasing, the dissolved plasma is also increasing, dissolved form. The solubility coefficient of the carbon dioxide is 20 times higher than oxygen. So there was a 0.3, and here is a 7% of this carbon dioxide is soluble form. It is transported. In the venous blood, that is a 46 millimeter of Ag in the venous blood is carried through this in the simple solution. This is a 2.76 milliliter per deciliter. Now in the bicarbonate form, bicarbonate 70% is the maximum amount of the carbon dioxide is transported in this bicarbonate ions and in the red cell. Why in the red cell? Because of this, the carbonic anhydrase which is present, the enzyme which is responsible for formation of the carbonic acid. When the carbon dioxide and water, it binds together, it forms a carbonic acid. From the carbonic acid is a bicarbonate. And in the red cell, it forms either in the both way, in the bicarbonate and also carb amino hemoglobin also. In the process of carbon dioxide transport in the form of bicarbonate, something happens called chloride shift. What is that? We can see in this diagram, this is the red blood cell which is taking the oxygen, bringing the oxygen, is bound with this hemoglobin, and this oxyhemoglobin, then it forms in the H plus ion. It is taking the H plus ion, so it is releasing the oxygen. Why oxygen is releasing? Because the tissue carbon dioxide is going from here. Tissue, there is a 46 millimeter of Hg, and the capillary bud, this is a 40 millimeter of Hg for the carbon dioxide, is diffusing from tissue to red blood cell. After coming into the red blood cell, as we know, this carbon dioxide in the presence of the carbonic anhydrase along with the water, it forms a carbonic acid. This step is not there, and this carbonic acid, again with the help of the carbonic anhydrase, it is broken down into bicarbonate and H plus ion. Because of this H plus ion, the acidity is decreased, the pH is decreased and acidity is increased. Because of that, hemoglobin will release the oxygen and it binds with this hydrogen ion. Okay, fine. And this oxygen, released oxygen, is unloaded to this tissue. Fine. This much is okay, over. And now what is happening here? Because of the continuous process, this is bicarbonate is producing in the higher amount. It cannot stay inside for long in the red blood cell. So what will happen, because of the concentration is increasing more compared to the outside, this bicarbonate will go out of the cell along the concentration gradient. But in this case, there is an anion exchanger protein is there. Whenever the one molecule of the bicarbonate is going out, the chloride, one molecule of the chloride anion will go inside, and this is called the chloride shift. Shifting of the chloride in exchange of this bicarbonate is called chloride shift. Now what is happening? As the carbonic acid is readily dissociates into bicarbonate and the hydrogen ion, the bicarbonate concentration increases inside the red blood cell. With the bicarbonate leaves the red blood cell, in exchange of the chloride enters to the cell from the plasma and maintains the electrical neutrality. It's very important because both are anion, and this exchanger, the protein, whatever it is called, the chloride bicarbonate exchanger or anion exchanger. Before it used to call the band 3 protein, band 3 exchanger. Now the chloride movement in exchange of this bicarbonate is called chloride shift. This phenomena is described by Hamburger, and that's why it's called the Hamburger shift or Hamburger phenomena. And the chloride accumulation in the red blood cell is causes the increase in the volume, because it's continuously increasing in this. Now continuation of the last slide. Because of the chloride shift, what is happening? It has been seen that the hematocrit or the PCV, the packed cell volume of the venous blood is more. Why? The effect of chloride shift. What is happening? In exchange of the bicarbonate, what is entered into the RBC is chloride, right? And because of the chloride, its content is increasing slowly in exchange of bicarbonate. What is happening? The chloride is very much osmotically active anion. What is osmotically active anion? Because of the presence of the high concentration of chloride, it drags the water from the outside of the cell towards inside of the cell. So what happens? The RBC imbibes water from the extracellular fluid, and because of the increase in RBC volume size of the volume in the venous blood, the PCV contains the PCV percentage increases by 3% in the venous blood because of this chloride shift. Now, very interesting part is a carbon dioxide dissociation curve, which is completely different from oxygen dissociation curve. It also doesn't look alike. And it is a really, because why it is doesn't look alike? Because of the linear relationship between the oxygen content and the PO2. Check this graph. The partial pressure of this curve, carbon dioxide is increasing, and the carbon dioxide content of the blood, the percentage of the volume is also increasing, and it is a linear increase. So within physiological limit, 40 to 40 millimeter to 46 millimeter of the curve is more linear and steeper. Because of this shape, little amount of the carbon dioxide increase or decrease, the loading and unloading with the hemoglobin, it is very faster. It is not like oxygen. And the inverse is a very interesting part, the inverse relationship between the PO2 and the CO2 content. So what is happening? We'll take this in the alveoli level. Alveoli level, the PO2 in the alveolar pulmonary capillary is 100. Because of this 100, immediately whenever the PO2 level is more, the hemoglobin cannot carry the carbon dioxide more. So immediately this hemoglobin will leave the carbon dioxide and it will diffuse out from the pulmonary capillary to the alveolus and exhale out to the through the lung. And what is happening? The exactly happening to in the tissue level where the PO2 is less. So because of the PO2 is less, in that case the hemoglobin has affinity to bind with the carbon dioxide more. In that case, hemoglobin will take the carbon dioxide from the tissue and binds with that, and in the carbamino hemoglobin it goes towards the right heart to where it goes to the lung and exhale out. So this effect, what is happening in the exchange of this PO2, the oxyhemoglobin saturation on the content of the carbon dioxide, is known the Halden effect, which happens at the lung level. We have to clear about the difference between the Bohr effect and the Halden effect. Bohr effect at the tissue level. Okay, it happens at the tissue level. What is happening? The carbon dioxide, which is produced due to metabolic activity inside the tissue by the diffusion process, it goes diffuses from the tissue to the blood, enters to the blood. And whenever it is entering to the blood, there is an unloading of the oxygen from the hemoglobin, and it facilitates the tissue oxygenation, right? And in case of Halden effect, what is happening? Instead of this tissue level, Halden effect happened at the level of the lung. What is happening? Loading of the oxygen with the hemoglobin, loading of the oxygen with the hemoglobin at the 100 millimeter of Hg, where the pulmonary capillary contains 100 millimeter of Hg, it facilitates the unloading of the carbon dioxide, which is carried by the venous blood. Okay, immediately the oxygen is coming, diffusing to the pulmonary blood, pulmonary capillary, and immediately there is an unloading of the carbon dioxide in the alveoli. So this, in case of Bohr effect, the shift of the oxygen dissociation curve towards the right, because of the unloading. But in case of Halden effect, the oxygenation of the hemoglobin, because of the hemoglobin binds with the oxygen, the carbon dioxide dissociation curve shifts towards right at the higher partial pressure of the oxygen. So this is called Bohr effect, which happens at the tissue level, and this is called Halden effect, which happens at the lung level. In that Bohr effect, the oxygen dissociation curve shifts towards the right because of the higher concentration of the carbon dioxide, where in the Halden effect, the carbon dioxide dissociation curve shifts towards the right in the presence of higher partial pressure of oxygen. Now what is this? This is the diagram of the picture of a pulse oximeter. Now everybody knows about that because of this is very important nowadays. It has to be present in this corona period in each and every house. So it is used to measure the oxygen saturation of the hemoglobin, and this instrument is called pulse oximeter. It is a non-invasive method for the measurement of the SpO2, the percentage saturation of the hemoglobin, and this probe is inserted into the finger or the ear lobule. And why? Because of the pulsatile blood vessels can be accessible externally. Because of this capillary beds are just below the nail, there is no muscle in this peripheral part of the body, and the red and the infrared lights are emitted from this instrument. It is battery operated, and this light whenever it is passing through the capillary, it is hitting the pulsatile material and the non-pulsatile, and the total absorbent, so light is emitting from this instrument, it is heating towards the hemoglobin molecule, and it is coming back and it is calculating. So total absorbance, it is calculated, and the pulsatile component of this absorbance represent the arterial oxygenated blood. Whatever the pulsatile, it is coming and it is heating, the light is heating to the hemoglobin and it is again coming. So how much time it is heating and coming means the total amount of the hemoglobin present in that blood. So this is SpO2 is measured, and the normal SpO2 is 95 and more, are higher till 97, 98 also. Some people, the chronic lung disease or the sleep apnea, it can be at the level of 90, and the 90% is normal for them. They have been accommodated by themselves with that partial pressure of the oxygen, percentage saturation of the hemoglobin. Now we have to summarize the oxygen and carbon dioxide transport from the lung to the tissue, from the tissue to the lung again. The oxygen delivery to the tissue from the capillary bed. As we know, there is oxygen, partial pressure of the oxygen, and the arterial end of the capillary is 95 millimeter of Hg, whereas the tissue fluid is 40 millimeter of Hg, and inside the tissue it is 23 because there is a metabolic activity is going on, so it is very less. So this gradient helps, this 95 to 40 millimeter, this gradient helps the oxygen to diffuse from the arterial blood to the tissue, and because of inside is more much less, it is again diffused from the tissue fluid inside the cell. So in this case, this oxygen, partial pressure of the oxygen at the arterial end is 95. After diffusion or the utilization or unloading of the oxygen inside the tissue, it becomes 40 millimeter of Hg. Now oxygen uptake from the tissue and delivery to the lung. And when the arterial end of the capillary, we know this is 40, carbon dioxide is 40 millimeter of Hg. Now what is happening, because of the metabolic activity is so much inside the cell, the carbon dioxide is generated more, and this is 46 millimeter of Hg. Now what is happening, because of the 46 outside, it is diffusing because it is less and it is becoming 45. Now the gradient is this tissue fluid has a more amount of the carbon dioxide compared to the arterial end of this. So the carbon dioxide will be transported from the cell to the tissue fluid, and from the tissue fluid towards the capillary bed. So venous end of the capillary bed. At the end of the venous end of the capillary bed, what is happening, carbon dioxide level, or the partial pressure of the carbon dioxide level, increases from the 40 to 45 millimeter of Hg, which is carried through the right heart, and from the right heart it has been exhaled out of the lung. So here we end the transport processes of the oxygen and carbon dioxide in the body. Thank you.